Okay, so can I introduce the next speaker? Nick Lansdale is well known to us in Liverpool, a consultant surgeon in Manchester. Nick is going to talk to us about, I guess, it's the medium and long-term outcome for children with esophageal atresia as they grow older. Thanks, Nick.
Okay, good afternoon. Thank you for the opportunity to come and speak to you all. As Professor Losty said, I'm one of the surgeons in Manchester. I'm one of 3 consultants who performs esophageal atresia, so picking up what Matthew Jones talked about this morning to you, we've subspecialised to 3 of us. We do, on average, 15 new cases a year, so even with that, we see about 5 each. I'd like to talk about the consequence and the impact of esophageal atresia. It's easy to think that really this is a disease for babies. The most intense, stressful part, the surgery, takes place in those first couple of days, but we need to think about this as a lifelong condition. And I know that's a little bit of a cliche because we talk a lot today about that, but I still don't think it's recognised around the country. So our interventions and our follow-up should really be targeted on a lifelong condition. The impact of esophageal atresia broadly falls into the 3 systems. So gastrointestinal, which I'm going to focus on, so that would be the esophagus, the stomach and the bowel. The respiratory system, which Dr. Narayan's already spoken about, and the skeletal system. I'm not going to talk much about that because that's largely focused on some babies that are born with problems with their spine as part of the sort of VACTERL or VACTERL sequence. And it's also not really an area of my expertise, but there's plenty out there, and it's certainly mentioned in the TOFS book. So in terms of GI impact, most of you will be familiar with these things: swallowing difficulties, reflux, effects of reflux, and long-term issues. So swallowing difficulties, well, why do they occur? There's a number of things. These are endoscopic pictures. You've seen some of these today already. The camera down the mouth, usually with children asleep, we use general anaesthetic for endoscopy. And you can see here a little pinhole of an opening. And most strictures occur where we've done the join, and we call that the anastomosis. And it's where the 2 ends of the esophagus are joined up with a series of stitches, usually. That is susceptible to narrowing, and we call that an anastomotic stricture. They're usually worst in the first year of life, but they can be made worse, particularly if you've got very bad reflux. You can get strictures in other places. You can get them in the lower esophagus, and they tend to be due to reflux. And so that's an acquired, you've got very bad reflux, it scars down and you get a narrowing at the bottom of the esophagus. There's also something called congenital esophageal stenosis, so you could be born with a narrowing. And those that are born with a narrowing, that's an association with TOF. So I had a baby I operated on last year, did very well for a year, had no problems, and then presented it a year with problems getting food stuck. And we found a narrowing at the bottom of the esophagus. We assumed it was a reflux stricture. We tried to stretch it, which we'll come across later. We tried injecting it. It just wouldn't expand. And in the end, I assumed it was an esophageal stenosis that the baby had been born with, and there was some evidence on the previous contrast. So we had to do another operation through the baby's chest and remove that segment of esophagus and join the end. So that baby has 2 joins in its esophagus, but thankfully seems to be doing better since that. So these strictures you can see here, this is a contrast swallow. This contrast swallow shows something else, this black hole in the contrast, and that's a filling defect, so the contrast can't get to this bit here. And that's because there's a food bolus stuck there. And that's when a piece of food or something else, that sometimes we've seen coins, we've seen all sorts, can get stuck at the area of narrowing. So that's another reason for swallowing difficulty. And finally, as our upper GI colleague in adult surgery spoke about this morning, you can also get this dysmotility where we can't find a narrowing, but because the esophagus isn't squeezing properly, you have swallowing difficulties. And so that's really a diagnosis of exclusion in that on endoscopy we can't find narrowings. Unfortunately, it is very prevalent and can have consequences, and it's related to anatomical factors, so the way we've plumbed things together, but also that the muscle of the esophagus and the nerves to it aren't normal in babies with esophageal atresia. So what should we look for? Well, I think in older children it's obvious. They choke, they get things stuck, and they can tell us. It's usually sausage or bread or apple. You'll know that a lot of you will know those foods that are more difficult than others. In younger babies, it's trickier. And it's difficult, and the problem with that is they may have quite an advanced stricture before they present to us. So the things that parents should look out for are excessive bubbling of saliva at the mouth. And certainly a baby I'm looking after at the moment, that's how we picked up the quite early streak, because there was just a lot of saliva. Taking longer with the bottle, so just taking longer to drain a normal bottle and that being a progressive thing is another good sign. In the slightly older children, you may have problems with food avoidance. You may have problems with certain more solid foods than milk, for example. And regurgitation very quickly of fluid or can be confused with reflux, and that does make it a bit tricky sometimes. So what does the research tell us? Well, this is a really good study from the US a couple of years ago. It's from the Mayo Clinic, and they showed that 80% of adults at 40 years of age had problems. So you think, well, okay, that's a bit of a worry, isn't it, 80%? But the good news from that was that it was often mild and didn't affect their food choices. So I think that's a positive thing. And it showed that 3/4 regularly drink sips of water with their meals. And it's worse for hard foods. Well, I don't think that's particularly surprising, but it's one of the first times that it's been well documented. And importantly, it didn't affect their quality of life. What can we do? Well, we can recommend lifestyle changes, so chewing your food well, drinking with food. If something gets stuck, use fizzy drinks, etc. Generally, my understanding is from parents that children learn this on their own. It's a subconscious thing. As they grow up from being a baby, they learn they have to chew well, they learn they have to drink with their meals. We can use medicines, particularly in strictures, because if you've got reflux and a stricture, the reflux makes the stricture worse, so we can use ranitidine and PPIs like omeprazole. Sometimes we need to do surgery on strictures, and the mainstay of that is using endoscopy. So we put a camera down and pass a wire, and then one of these balloons, and you can see this little egg timer at the side here, which is where the stricture is, and then it expands and is lost. If a stricture doesn't come up, we sometimes inject steroids here, using a little needle down the camera, and that can help. And the Americans have reported using a knife and actually cutting strictures with good success. I haven't got any experience, I don't know in the UK that's doing that, but might be something for the future. And finally, if you've got very bad strictures and very bad reflux, sometimes surgery is needed to prevent that reflux. And I'll talk a bit more about that later, but that would be usually in the form of a fundoplication. And that can be very successful for what we call recalcitrant, so difficult to budge strictures. Reflux. So you'll all be familiar, I'm sure, with reflux. The difficulty with reflux is it presents in many, many ways. It's due to those factors I talked about before, which are mechanical in that the plumbing, there's physical changes in the esophagus, so we've pulled it up to join it. There may be a acquired hiatus hernia, which is where some of the stomach's in the chest, but also the esophagus doesn't squeeze as well. We know that the muscle's not normal, and we know that the nerves to that muscle aren't normal. So it can present largely for GI symptoms or respiratory symptoms that Dr. Naren's already spoken about. The problem with reflux, as well as it being not a particularly nice experience, is that it can cause problems. And again, those are the respiratory ones that we talked about earlier, but they can aspirate. We can get these death attacks or apparent life-threatening events. It can worsen the malacia that we talked about, and you can cause chronic lung disease. Esophagitis is where the acid coming up irritates the lining of the esophagus, and particularly over a long period of time, that can be a problem. And it can be a problem because it can cause changes in the esophagus, which we call Barrett's esophagus. It can also cause strictures, where the scarred esophagus from the acid narrows down. Babies that are vomiting or regurgitating lots of milk fail to thrive because they're not getting their calories in. So that's another important thing to consider. And impaired quality of life, well, those symptoms aren't very pleasant. So how do we manage reflux? Again, you'll be very familiar with this, I'm sure. Lifestyle factors. We know that keeping babies upright can help, feeding them upright. When they're in their car seat, having them in a good upright position rather than being slouched. At night time, not having them lying flat, propping the head of the bed up. Parents come to me and say, that is very helpful. Some of the books state otherwise, but I think it's always best to listen to the parents in those situations. If it works for them, then it works. Food types, particularly in older children, we know that food types can influence that, and reflux is made worse often by very fatty food or very acidic food. But even babies can have modifications, and we know now that some of the European guidance suggests that in refluxing babies, the first step should be to change the milk rather than to put in things like acid suppressants. And that brings us on to acid suppressants, medicines. You'll be familiar with ranitidine and omeprazole. It is a controversial area whether or not esophageal atresia patients should be on routine acid reduction. We adopt a strategy for the first year of life. We have all babies on ranitidine and then review that depending on how symptomatic they are. Ranitidine is usually easier to give to babies because omeprazole often has to be dispersible. It's a bit trickier, but omeprazole may be a bit more effective. So in the older child, putting it in yogurts and things is useful. There was some brief talk earlier about the long-term uses of PPIs and potential consequences. I think really that has to be balanced with how symptomatic children or young adults are with esophageal atresia and whether they need those medicines. The other class of medicines to mention is the prokinetics, so things like domperidone, erythromycin, cisapride now been discontinued. But I don't think the evidence for those is as good, really. I think parents come and tell me that domperidone works well for their child, and when they've stopped it, their child got worse. I think, fine, yeah, that's a good reason to use it, but in a lot of babies and children, it doesn't make much difference, and it's not effective on the esophagus. We know that, so it's not going to help your esophagus to squeeze food down. It might help your stomach empty a little bit better, but largely we don't use a lot of prokinetics now. So once we've exhausted medical therapy, if you're still having complications of reflux, so that would be failing to thrive as a baby or recurrent respiratory problems or a stricture that we can't treat, or a bad esophagitis or Barrett's or a hiatus hernia, then we would sometimes need to do surgery. And the mainstay of esophageal atresia patients with anti-reflux surgery tend to get a fundoplication. This one is a Nissen's. It's a 360-degree wrap of the fundus round. The literature states that as many as a quarter or more, or in some centres have reported higher rates of babies with esophageal atresia ultimately requiring this surgery. I think it's probably a little bit lower if you look nationally now. It's probably less than 20%. We do find it useful. The evidence suggests that children with esophageal atresia do worse than patients that don't have esophageal atresia who've had fundoplications, in that there's a high failure rate. My experience, and I'll acknowledge it is a limited experience, but also talking to more senior colleagues, is that it can be very, very helpful, and particularly in curing strictures. We tend to do them with keyhole surgery now, and if it's done young, is usually a relatively straightforward operation to do keyhole, and with fairly short length of stay and quick recovery. So certainly now we see that it can be very useful. So coming on to Barrett's esophagus, this is where the lower gullet, just above the stomach, the lining, it changes from this squamous cell, which is a very flat cell, to a columnar cell, which can be either gastric or intestinal type. Now, it's known to be caused by recurrent, so long-standing reflux of acid up into the gullet. We diagnose it with endoscopy and biopsies. You can suspect it by looking with the camera, but to prove it, you need the biopsy, so taking that little pinch of tissue. The definition, it is controversial, and it's controversial even outside of esophageal atresia in TOF, but it's particularly controversial in TOF at the moment. The definition is controversial because some people say it should only be the intestinal type, which has the highest risk of then turning nasty, but generally people are causing any what we call metaplasia, either to a gastric or an intestinal type. They're calling this Barrett's. It needs to be done with a very protocolized biopsy. You can't just do one biopsy and say you don't have Barrett's. You need to have 4 quadrant biopsies every 2 centimeters in the gullet. And there is protocols like the Seattle protocol for that. The relevance of these findings, particularly gastric metaplasia, though, is controversial. So again, looking at the evidence, this is an excellent paper from France, looked at 120 teenagers, and they showed that 43% had Barrett's, but only one of those 50 patients had intestinal type. And we know, as I said, the intestinal type is the risky one. That's the one that really should be kept, and I'll talk a little bit more about that. This is a review of other papers that have looked, and the rates are anywhere between single-figure percents to what we've got, 30, 36%. So this 40% is the highest have been reported. They did use protocolized biopsy, so it was a very good, robust paper in the Annals of Surgery. So what's the risk of that? You know, that's what we want to know. Just because it's there, you know, that might not make any difference, but what is the risk of this actually causing a problem? The risk that people talk about with Barrett's is transformation to a precancerous lesion or a cancerous lesion, so an esophageal carcinoma or, essentially a cancer of the gullet. It's very difficult to quantify. Most of the data we have is from adult studies, and these are not TOF patients, these are just adults with Barrett's. The current estimates are about 1 in 1,000 per year can turn to either a precancerous, or what we call dysplasia, or to a malignancy. However, we need to caveat that. This is generally the intestinal type, and we've already shown that most of those TOF children had gastric type, and that's thought to be at least 3 times less likely to turn, if you like, if that's the correct term. It tends to be longer lengths of Barrett's, so greater than 3 centimeters, and again, that's probably not what we've been seeing. And other factors are important, so males and genetic underpinning of Barrett's is very important. And I think the take-home message here is there's still only very, very few worldwide cases of malignancy been reported. People always quote 8, but certainly there's been papers since people have been quoting that 8. I think we're probably nearer to 15 now in the worldwide literature. It was very difficult for me to get an accurate figure. Certainly less than 20 have been reported worldwide, and that's from tens of thousands of patients born with esophageal atresia. So we know that that risk of malignancy is low, but if there is Barrett's there, then we should know about it. So what should we do about it? Well, we need a structured follow-up. We need endoscopies at fixed time points so that everyone is reassured. The guidelines coming out of Europe and North America, joint NASPGHAN-ESPGHAN guidance, which is based on just a consensus of professionals, not so much evidence, but still is useful. They recommend doing 3 sets of biopsies. 1 in children when you stop their PPI. You do 1 when they're 10, and you do 1 when they're doing transition. The Dutch model is similar to this. They recommend 12 in transition, and that's the policy that we're using in Manchester in our MDT. So we're going to aim to biopsy at 12 and then at transition. If Barrett's is found, then you go to this more regular endoscopy. And this is what the British Society of Gastroenterologists talk for. This is for all adults with Barrett's. But as you can see, if you've got gastric metaplasia and it's less than 3 centimeters, you repeat it and then you can get discharged. So it needn't be a huge burden if we're just showing gastric metaplasia rather than intestinal type. And similarly, this can be treated. It's important to say that Barrett's can be ablated. It doesn't mean having to remove the esophagus. You can use a camera and endoscopy to treat the Barrett's. So almost finished. Esophageal replacement, special cases. So babies born with long gap esophageal atresia or who have had problems with surgery often have their esophagus replaced. In the UK, we know from the national study, the national survey in BAPS-CAS, that the most commonly used way of replacing the esophagus is the stomach, a gastric transposition. You can also use jejunum. I know that's being used quite in Bristol. Some people are still using colon, but certainly the stomach is the most common. And there's a paper just published from GOS, in fact the first author's in the audience, looked at 32 patients with a gastric pull-up and compared these to 32 other TOFs. And these were a long follow-up patients, so back in sort of even, I guess some of them had before Spitz or all Spitz, yeah. So very, very big experience that Lewis Spitz had in GOS. They managed to get responses from 32, and interestingly, their symptoms weren't grossly difficult. They had a bit more reflux than other TOFs, which were primary repaired, but their dysphagia was probably not quite as bad. and their vomiting was similar. So symptom-wise, you think, okay, all right, this looks okay. But look a bit deeper. They're underweight compared to their primary repair peers. So their BMI is low, or certainly lower. Nearly half were anemic, and a quarter had symptoms of dumping. So that's where you eat a meal, particularly a large meal, and your blood sugars drop. It's a very difficult problem to treat. You can modify the way you eat, and certainly we're looking after a patient at the moment who has some of these symptoms. And then about a fifth are requiring supplementary feeds, so tube feeds. So the take-home message here really is that when you have to have your esophagus replaced, there is a long-term burden, and long-term follow-up of this is absolutely key to address problems like the anemia and the dumping. So finally, just to finish on the overall impact of esophageal atresia, this is another excellent study published last year, EAT-1. It was a huge study from 25 countries using the International Federation, of which TOFS is a member, and 1,100 respondents from 25 countries. So really, really good work. And again, Ed's involved in this. Some positive notes, I thought, that only about, 16-17% reported significant impact on their quality of life. The rest was either none, little, or some. So, we're showing here that a large majority can have a pretty normal quality of life. I think that's important for new parents when they're particularly facing the trauma of that new diagnosis. The frequency of their effect or the effect of TOF or esophageal atresia on their ability to form relationships, again, over half said never had any effect on their ability to form relationships, and only really 10%-ish had a frequent effect. So again, quite positive. Looking at effects on family members is a little bit different. So over half report some more significant effect on their family members, and I suspect this is the parents and carers of those children with it, and it obviously has a big impact on their lives. And then finally, education and work, what's the effect here? And I think there's two messages I'd highlight here. One is that when you're an adult, actually, a big proportion is either none or very little effect. So that's good. It's shown that TOFS and esophageal atresia, children that grow up and become adults can work and have education that's pretty good. What concerned me a little bit was here in the under fives, was showing that a good number, over a half, have some more significant effect on their education or their work. So that might be the work of the parents or their carers, or might be the child's schooling or nursery and then schooling. And I think that's something we really need to be cognizant of and address, and perhaps support those schools or carers or the parents' place of work. And I think TOFS as a charity is well positioned to address those sorts of things. So thank you very much for listening. This is our group of MDT that look after our neonatal surgical patients with neonatologists and nurses and things. And if you'd like to get in contact with my email. Thank you very much for listening.